Probably challenging. I know it's probably challenging for some of you, especially if you live in the East Coast of the United States, because we've got lots of snow and ice. But thank goodness for Zoom that we are still able to be here and meet and hear these presentations. So I am an associate professor at the M. Louise Fitzpatrick College of Nursing at Villanova University, which is a institution very supportive of my research. And I also am in clinical practice as a nurse midwife at Pennsylvania Hospital in Philadelphia. So that is my background. And next slide. Okay, so disclosures, I have been a research consultant for VasoWatch LLC. And the objectives by the end of this presentation, you should be able to describe the significance of postpartum hemorrhage in relation to maternal morbidity and mortality. Not probably much new information for those of you who have worked in this field for a while. The main focus will be to describe the lived experience of postpartum hemorrhage as expressed by the participants in this study, and then also some practice implications for midwives, nurses, and obstetricians who care for parturients with postpartum hemorrhage. So we're all familiar with the UN Sustainable Development Goals and SGD3, in particular maternal mortality, target 3.1 by 2030. We hope to reduce the global maternal mortality ratio to less than 70 per 100,000 live births. It does not look like we are going to meet that target. Some important things to think about as well as we reflect on how can we better meet that target is to remember that maternal health and newborn health are very closely linked. And I don't know if any of you are familiar with the work of Eugene de Klerk at Boston University, but he has done some really elegant work showing how when mothers die, babies are more likely to die. So for those in the community that are more concerned about babies, we got to keep them together and we got to save them both. Timely management and treatment can make the difference between the life and death for the mother as well as the newborn. And that's part of what the focus is if you look at the WHO roadmap to combat postpartum hemorrhage that is from 2023 to 2030, is how can we enact this better throughout the world, as postpartum hemorrhage is the most common cause of maternal death globally. While most of those deaths do happen to occur in lower income countries, in sub-Saharan Africa and South Asia is where the majority of deaths are, it is still a problem in developed countries as well. This is actually from a table from the CDC when they looked at data from 36 states that had maternal mortality review committees through 2019. And they found that hemorrhage, you can see here, is the second leading cause of death in the US. Now, I will have to say this chart was originally retrieved from the CDC, but as some of you may have already discovered, in January of 2025, a lot of the data that the CDC kept has been scrubbed. Okay, and that was really concerning to see that that data was scrubbed. They say it's archived, but it's very difficult to find, and you cannot find the entire amount that you were able to see in the original posting of this data. So fortunately, there is an organization, which I have here in the corner of the slide, called restoredcdc.org, and it actually has the citation where you can find this table. And so this is a group of volunteers that are aiming to restore the CDC data that was removed in January 2025, if you want to go explore that site. Okay, so can we predict postpartum hemorrhage? We use various assessment tools commonly in the US, the CMQCC, the ACOG tool, and also the Association of Women's Health Obstetric and Neonatal Nurses tool, which we use an adaptation of that at our own institution, Pennsylvania Hospital, where I practice. But we know these tools are not very good. In many studies, something like 40% of the patients that hemorrhaged were initially designated as low risk. So we've got to be doing better than that. So that was the idea for our parent study, on which the study I will tell you about today came from. And this study was presented at SMFM in 2024. And it's called the Derivation and Validation of an Intrapartum Algorithm to Predict Postpartum Hemorrhage Using Photoplethysmography, or PPG for short. Okay, the objectives of that parent study were to see if we could develop an algorithm using non-invasive PPG data to provide intrapartum decision support, indicating patients at higher risk of requiring postpartum non-prophylactic interventions for hemorrhage. The reason we chose that as our outcome or as our primary aim is because we all know the difficulty in estimating blood loss accurately, and quantifying it also has its problems, but tends to be better. But we thought this is a real objective measure. At this particular institution, everyone after the delivery of the placenta or after the delivery of the baby, to facilitate the delivery of the placenta, the earlier the better, gets either 10 units Pitocin IM, or at that time, 20 units of Pitocin in a 1,000 cc IV bag. So that was the prophylactic dose. Who required it? This was to see who required additional medication. So it was designed using machine learning, which is a form of AI, with the goal of having the resulting model target myometrial fatigue for predicting need for PPH intervention. Now, myometrial fatigue is not a term you're going to find in the clinical literature yet, but we believe that that precedes uterine atony, that there are signs that the muscle is fatiguing, and that precedes uterine atony, which we know causes about 80% of postpartum hemorrhage. So this was a prospective observational study at a large academic tertiary medical center. We did receive IRB approval before performing any study activities. Patients had to be 18 years or older, singletons, no multiples, and they had to be full term. Okay, so what were the demographics of the study? We enrolled 525 patients. This was the racial mix. You can see 25% Black, 62% white, 12% other, mostly privately insured. MDs attended 67% of the births, CNMs, certified nurse midwives, 32%, 68% vaginal delivery rate, and a 27% C-section rate, which is kind of on par with our institution in terms of what we tend to have in terms of institutional levels for C-sections. I thought this was quite interesting. 46% were admitted in spontaneous labor, 53.3% were inductions. So we had more inductions than we did spontaneous labor admissions. And then you'll see this graphic on the right. This figure is showing those folks who underwent the PPG analysis. For that, we had an N of 371 because the signal that transmitted the maternal heart rate data, that was what we were looking at. It was transmitted via secure Wi-Fi, and sometimes the signal connections did not allow for full transmission of the data. So we had full data for 371. And what you can see here is that with the PPG algorithm, we had 3 times better prediction of folks needing uterotomics compared to the standard screening tool that we used. 45% we were able to pick up versus 15%. So that was the parent study. Now, what about qualitative research? That's what we started to wonder. What was it like for these women who were undergoing this study? There's a lot of research about healthcare providers' experience detecting, preventing, and managing hemorrhage, and I list some of the citations there. HOMA was involved and actually was senior author on a paper that looked at providers and patients' experiences with postpartum hemorrhage, looking more at identification of risk. Did they know risk? And also prevention, and how did patients feel about receiving preventive medication? They were very favorable about receiving preventive medication for hemorrhage. And HOMA, during question and answer, if people have more questions about that study, you can talk about that since that was yours. There are some qualitative studies specific to emergency hysterectomy post-PPH, but that's a very different kind of a unique situation, not PPH in general. The lived experience from the patient point of view with PPH was all from countries outside of the US, many developing countries. Not sure if you could apply the same findings to the US. And so we found that there really was a gap in the lived experience, studies of the lived experience of PPH in the US. So we identified that gap. The voices of US women have been missing from the existing research. So it is needed on the lived experience of survivors. And our aim was to describe the phenomenon of experiencing a postpartum hemorrhage during childbirth and to hear it from women in their own words. So these were our methods for, yes? Okay, I heard somebody talking in the background. So this was a descriptive phenomenological qualitative design, and we received IRB approval from Villanova University and University of Pennsylvania. The first study was done, actually, the parent study at Penn when all of us on the team were all at Penn. But since then, I have left to go to Villanova as a faculty member, and Dr. Weimer, who is the engineer on the study, went to Vanderbilt. Stephanie Modry remains at Penn, and Mary Beth Murray is with me at Villanova, and you'll hear about them later. Purpose of sampling from the larger parent study showed that 70 women were eligible. So out of that 525, 70 had hemorrhages, and we used the criteria for eligibility of the 1000 cc ACOG definition of postpartum hemorrhage. And of that, 57 agreed to be contacted for future study. Study information and informed consent forms were stored using REDCap. We did semi-structured individual interviews over Zoom for about 45 to 60 minutes in length. So those are quite substantial. Women really wanted to talk. Audio recording, transcription, and field note-taking occurred during the interviews. Okay, so data analysis was conducted by 2 independent researchers, line-by-line analysis according to the method of Van Manen. An inductive approach was used to code the data and identify patterns or themes, and that thematic analysis was done according to the method of Brown and Clark. Data collection continued until no new themes were identified. Okay, and whenever you do qualitative research for validity and reliability, Lincoln and Guba kind of set the tone that these are the things that you need to evaluate: credibility, dependability, transferability, confirmability, and reflexivity is another one that they've sort of added. So really 5 criteria, now that we've added reflexivity in there, were considered in the data analysis process to ensure the validity and accuracy of the results. Okay, so we ended up with 10 participants, which if you're used to quantitative studies, you're like, really, 10 participants? But for a qualitative study, that seemed to be a respectable number. I mean, and again, we continued to interview until we reached data saturation, and we did reach it with 10. The participants had a mean age of 35.2 years. 1 participant had a vaginal birth. 9 had cesareans. The breakdown race and ethnicity, we were kind of pleased that for such a small group, we had a nice little mix. White non-Hispanic 6, 2 Latino women, 1 Black, 1 Native American. Okay, so these are the themes. First one, midwife-physician communication. You would not believe how much we heard. I wish I had been told. I would have been nice to know that I'd had a hemorrhage. I was never actually told that. I remember the nurses saying I had lost a little more blood than expected. I don't know if that has anything to do with it. I had to take iron and get an iron IV. I was never told that. They had me actually on bed rest for the first 24 hours. So this woman had been on bed rest for 24 hours, and no one had really explained to her why she had to be on bed rest for the 24 hours. I wish they'd told me. So there really was an express need that their provider needed to be the one to communicate this to them. And there was actually one expression of appreciation from one patient who said that her midwife did actually come back and talk to me. And she actually even used the word debrief in her quote. And now let me pull that right here. Thought it was very interesting. The midwife who delivered me came back into kind of like debrief, which I thought was just really kind. You can see I have my written transcripts in front of me in case I wanted to pull more quotes out. I promise I won't do that again during this slideshow. I know I only have 15 minutes, but it's just amazing the rich quotes that we got from these women. Okay, theme two, traumatic birth experience. I remember that the whole birth as a whole felt a little traumatic. Felt like I was hit by a truck. It was a blur. My husband was pretty traumatized. He was very nervous coming to my second delivery. So these women use the word trauma when that word was never mentioned in the questions. So I just, want to point that out, that our questions were not like sort of leading questions with specific words, but what memories do you have of your birth? What was it like? What did it interfere with your bonding or care of your infant? Do you think what can be done to make labor care or postpartum care better? Very general questions. And of course, with qualitative research, you kind of see where the participant takes you in their response, but these words were coming up spontaneously from these women. Okay, third theme, need for emotional support and education. I really feel like postpartum hemorrhage did interfere with my breastfeeding. That was a very common complaint. I kind of felt like I was forgotten at the expense of getting the baby out. A little bit more attentiveness to me as a human could have been helpful. And this was another word that came up spontaneously several times, the word vessel. Mother is more than a vessel for a baby. Remembering that the mother is more than just the vessel. These are direct quotes that's delivering the baby. While getting the baby out as safely is the number one priority, the number two priority should be like the mental health. Okay. Um, just listen to the patient. And it could have been helpful to have a more extended in-person conversation with some guidance. Okay. And then also postpartum needs after leaving the hospital and then impact on future pregnancies and births. So this quote was very representative. I think postpartum hemorrhage did kind of help make my decision for when I had my second baby. I know that there's a risk of it happening again. It puts a little concern in me if I were ever to want a third one, it could happen again. I think it would be nice if there was more attention to postpartum. I think it would have been nice for someone to have mentioned postpartum needs, postpartum depression, because I felt pretty awful after I went home. So there was one study out of the Netherlands where they had asked the folks in their study if they would have liked counseling if it had been offered to them, and they overwhelmingly said yes, they would have liked that. So this was a different country, but I just thought it was interesting to look at these quotes and compare them with the other literature that is out there and what the findings were. Okay, so theme five, finally a really strong positive here. The healthcare team, made a very dramatic thing less traumatic. I really do feel as though they took care of me and took the burden of stress off me. We were both just so impressed with the coordinated efforts to reverse the problem that was happening. So it was really quite heartwarming to see the appreciation that these participants had for the teamwork in terms of for these patients in getting them safely through in terms of their physical survival and needs. Okay, what were some studies limitations? It was conducted at one medical center in an urban setting in the northeastern United States, which may limit the transferability of the findings. All of the participants had private insurance. As I said, the breakdown of all the people in the parent study was 72% private, but for this particular group, for this study, they all had private insurance. The timing of the interviews was 3 years after the birth, suggesting a larger possibility of recall bias, although one study that interviewed patients 4 years after the birth found the observation that the closer the interviews were to the actual birth, the more positive spin the patients put on the experience, whereas the longer the time had elapsed, it tended to be a little more negative. And they surmised that perhaps they had a time that gave them time to reflect on what had happened to them. So, but clearly we see that as a limitation, possible limitation. Okay, so implications, looking at the themes from the data and summarizing them. Theme one, midwife-physician communication, and I believe, Homa, that was something clearly that you also found in your study, that communication with a provider is so important. Women want to know. They want to know the details, and you may not be able to, of course, in that moment, you are looking at saving this person's life, be able to have extensive verbal conversation, but go back afterwards. Go back and talk to her on postpartum rounds the next day. It really makes a difference. Traumatic birth experience. A traumatic experience may need special counseling in addition to having the provider talk, as well as the nurses providing supportive care. Need for emotional support and patient education. There were some actual very positive things said about the nurses, especially around continuity of care. Several of the patients expressed that when they had the same nurse for several days in a row, that made them trust them. And I think there are implications for staffing around that. Theme 4, postpartum needs and impact on future pregnancies and deliveries. That was very clear that many women were hesitant to have another birth, or approached it with great fear because of what had happened before. Teamwork recognized and highly valued. So I think it's so important, the culture at the institution where this took place. I have been there over 20 years, and the reason is I really appreciate that teamwork really does happen there, and anybody on the team is recognized as having a voice and speaking out. Our goal is all for the patient, and that culture really does, I think, support good care. Women's needs are complex. They should have insurance coverage through year one. So in the US now, while we're facing cuts to the Affordable Care Act or some type of, who knows what's going to come out of that, we have data that show states that extended their Medicaid benefits through the whole first postpartum year, decrease the maternal mortality in those states. So we have several states where that's been the case. Okay, so I'd like to thank the women who participated in this study. Also, we had a subaward from the NIH, National Heart, Lung, and Blood Institute, and then the study team members who collaborated and were part of the parent study. Mary Beth Murray, Stephanie Modry, James Weimer, Harisa Dev, Amanda Watson, and Ninsip Lee. In particular, Stephanie, who participated in both of these studies, the parent and this one, and Mary Beth, who was like my North Star in working through this qualitative study. So thanks to all of you, and thanks for your attention.
Thank you so much, Kim. I really appreciate you sharing the slides and your research. I wanted to open it up for questions, but while we have any, you could just raise your hand or put in the chat. I wanted to say it's the reason I was so excited and looking forward to including this is it's a really unique perspective, right? The mental health, the toll it takes on women, and I only think in the last couple of years, funding agencies have started to pay more attention to that, and because it's what's important to patients, right? Besides the health outcome, I think this is really critical. So I really appreciate you sharing that. Any questions from the? Is that admitting some other folks? Dr. Wong, Cynthia Wong.
So it's not really a question, but a comment. So we have protocols for postpartum hemorrhage, and this brings up the question, should some kind of prophylactic mental health effort be included in our postpartum hemorrhage protocols?
I think that's a great idea. And, I don't know if in your institution we typically debrief as a team whenever we have an event like postpartum hemorrhage, shoulder dystocia, et cetera. Um, but we don't include the patient in those debriefs. And I think perhaps that's something to think about in once we have our um, team debrief, go back and make sure you follow up with the patient and yes, and suggest some type of mental health follow up. Even just perhaps we have a social worker who will meet with our patients if they have any particular concerns. But I think that's a great idea, Dr. Wong. Thank you for suggesting that.
Yeah, no, I agree completely too. And Dr. Small, you had a question. Marie
I
Small.
was actually that was really a really nice presentation. I was gonna make a similar comment or question. I know some with shoulder dystocias, that's kind of written into our guidelines that we're supposed to do it, and a lot of that the forces driving that are decreasing in litigation. But I think you really highlight why it's important to structure. We usually have social work see someone who has a severe maternal morbidity. I'm at Duke University, and but I think you just highlight just how important it may be to actually put that into, like guidelines and have some structured questions that are asked or certain content that's reviewed when you debrief with a patient who's had postpartum hemorrhage and addressing some of those stressors and traumas afterwards, potential touch points. And then
Yes.
not using the language hemorrhage, you bled more than normal or you bled more than average, but then a study comes along and says, oh, you had a postpartum hemorrhage. Do you want to participate in this study? And they're like, I had what? So, making sure people
Mhm.
are aware of the language that is associated with what happened to them is also, you highlighted that.
Yes, thank you for recognizing that. I appreciate that and your suggestions. Thank you.
Yeah, and to piggyback on that, I would say shoulder dystocia, while it's completely, recognized obstetric emergency, it's much less common, right, than postpartum hemorrhage. And so it makes sense for us to have a little even more concerted effort on those kind of things that affect more patients. Stephanie, go ahead.
Hi, I just want to add that our institution, some of our providers will do an immediate follow-up with the patient. And then in addition, they will try to make sure that they can see them during their outpatient postpartum appointment, which we usually do around 2 weeks. We will try to follow up with them as well in case any new questions came up. And they're happy to fully go over the full debrief again. And I think it's been a nice trend. It hasn't been written in our policy or like a full action plan for everyone to do, but it's been a good trend that's been happening. And
Thank
I love what Dr. Small said about building that into that whole PPH protocol. I think
yes.
it's very valuable.
Thank you, Stephanie.
Looks like we have a question in the chat. Uh, Dr. Rule, there may be a difference in perception in who had transfusion with those who did not have it, maybe?
So we didn't distinguish that. The requirement to be eligible was the 1,000 cc blood loss. I will tell you that none of the patients had a postpartum hysterectomy. We did have Bakri balloons, transfusions, one JADA within that group, but we didn't distinguish between those who had transfusions and those who didn't. But that would be an interesting future study. Thank you.
Yeah. Thank you. Any other questions? Oh, I see. Sarah Bell.
Very much for a really lovely presentation. Sorry, I've got two screens and it looks like I'm looking in the wrong direction. There we go. So just a question really about what was it that the women were finding traumatic? Did you manage to dive down into that and understand what it was about how the teams were being mobilized and what it was about the event that we can look to try and address when we're managing cases of postpartum hemorrhage?
Yeah, so the quotes that I have basically describe the experience in their words. They There were some more explicit descriptions that I didn't put all the quotes in, but for example, one patient said both of her arms, she was totally immobile with both of her arms, and she was very pale and she felt weak. Um, and so, there were more specific descriptions such as that, but um, to be honest, I can't say that they went into deeper descriptions of what the word trauma meant to them. It was just as we were listening, their perception of what happened. This was a word that they used. So that would be another further interesting study to kind of dive deeper into what they meant by that. Thank you.
Thank you. That was a great discussion. And for sake of time, I'm going to shift gears to allow Dr. John Tucci to present next. But if anyone has further questions in the chat, feel free to include them. If we finish a few minutes early, we can certainly go back to you answering any questions further, Kim. All right. So, John, if you could kindly introduce yourself briefly first, that would be wonderful. Thank you for joining. And one of the other things I love about this Unite Globe platform is we have a variety of speakers from all kinds of different backgrounds. So excited to include someone from transfusion medicine in this conversation, which is a critically important piece to the management of severe postpartum hemorrhage. John, just a side note, you're in presenter mode. If you want to share it to...
Trying to get it switched over.
Okay. Sounds good.
Got it to work a second ago, and then now.
Yes.
Failing, of course, right? While I'm trying to manage this, I will introduce myself. So I am John Tucci. I am an assistant professor in transfusion medicine here at Vanderbilt University. And so what I am going to be presenting is the culmination of about a year's worth of work now on pathogen-induced cryo. In the context of obstetric postpartum hemorrhage, and hopefully you can see the correct slide now. And so I do want to say thank you to Sydney and to Homa for allowing me the opportunity to share this project with you all and share, I think, what's an exciting new way to provide early fibrinogen to these women, and something that I hope is also generalizable outside of a large academic institution, and especially to those areas that may not have the opportunity to have long-term frozen storage or have the opportunity to thaw blood products on demand. So with that, I do want to disclose that I am briefly touching on one fibrinogen containing product that we originally used in-house, that's from Octapharma. And then now the rest of the conversation is around another pathogen-reduced fibrinogen containing product that's from Cirrus Corporation. Both have provided research funding support. So to briefly introduce Vandy, we are a massive institution, and this is even outdated as of last year when I pulled this, because now we have 8 hospitals at the end of the month, pretty much across the majority of Middle Tennessee. But of this, what's actually not shown here is that Vandy over the enterprise has over 6,000 live births annually, and overall 54,000 plus transfusions. So we are a heavy utilizer of blood throughout Middle Tennessee and even in the clinics outlying other neighboring states. But we have a very, very strong obstetric program, and that also unfortunately uses quite a bit amount of blood, and I'll explain a little bit of that. So as some or all of you may know, currently, at least in the US, we have 2 main ways to provide fibrinogen to women experiencing postpartum hemorrhage. And the 2 main ways are traditional cryo or cryoprecipitated AHF, and the newer form, which is just a fibrinogen concentrate. And there are varying differences between these. Most notably, traditional cryo has to be stored frozen and has to be thawed on demand. There are FDA regulations here stateside in terms of delineating what fibrinogen content it must hold. Typically, we actually will pre-pool these in at least a 5-pack that can provide up to about 1 gram or more of fibrinogen, in addition to the other factors which are helpful to help stabilize clots, not just provide the upfront fibrinogen. However, the problem for cryo is that it does take about, at least in our hands, about 30 minutes to thaw. And then once you do thaw, it because it is an open system, it has a pretty limited shelf life. And so if it is unused at the OR or at bedside, we're really unable to restock it. And so unfortunately, there's a lot of cryo waste due to this fact. Fortunately, among all blood products, it is relatively the cheapest. And so still stateside, it's about $300 to $400 for 5-pack in the US. Because of that thaw time and the delayed delivery of fibrinogen, especially in the postpartum state where early fibrinogen is useful, fibrinogen concentrate has been increasingly more popular in the fact that it is able to be stored lyophilized at room temperature. And in some institutions, such as our own, it is allowed to be stored in the OR in a Pyxis unit. So the anesthesiologist can actually pull this on demand. They don't need to place an order. They don't need to give a call down to the blood bank. They can essentially pull this, reconstitute it themselves in about 10 to 20 minutes and be able to provide that fibrinogen bolus. Each vial provides 1 gram of fibrinogen. However, all of these benefits come at a cost. So this is much, much more expensive than traditional cryo. And because of this, at many institutions, again, including our own, this is also a heavily regulated product by the P&T committees. So as part of another study, we are essentially trying to do a cross-sectional analysis of what exactly does fibrinogen concentrate use look like throughout our institution, and actually looking at it retrospectively over the first 18 months that we had it on board here. It was used sparingly, and that was because of the heavy regulations behind where it could be used. And we only had 43 usages of that in an 18-month period. But as you can see, the vast majority of those was actually within postpartum hemorrhage. And I will say, in the 18 months, this was over 2.5 years, and then the 18 months since this poll of data, fibrinogen concentrate use has tripled in our institution, again, with about the same proportions as well. So our women that are requiring early fibrinogen during postpartum hemorrhage primarily get fibrinogen concentrate, and they usually get it within about the first 15 to 20 minutes. And again, so the question is so why has our institution shifted to this much more expensive fibrinogen concentrate? And it really because we were experiencing much longer wait times for these women to get cryoprecipitate and get that fibrinogen needed to try to obtain hemostasis. And so by institution, this wait time can vary, and that largely depends on the ability of the institution to meet that demand, in particular the options that they have within their blood bank to be able to thaw, to be able to store cryoprecipitate. And so some places it can range almost up to 3 hours. And then again, I mentioned that short shelf life. So there's an inability to actually be able to keep this and maintain this product, leading to very, very high wastage rates and essentially lost costs for the institutions. And this is where the INTERCEPT technology comes in. And some of you may have already be familiar with this in some of your own institutions. This is something that's also used in platelets and has proven very, very effective in reducing sepsis-related transfusion reactions due to platelets. So INTERCEPT platelets or pathogen-reduced platelets traditionally use the same type of technique, and it's the same techniques that gets used for cryoprecipitate just during the plasma phase of production. And essentially it works off of this amotosalen or sorrelin backbone that will intercalate within the DNA here, and then upon UVA exposure, it will cross-link and essentially inactivate any type of pathogen or even white cells that remain within the unit. And so because of this, one of the most important things is that given that this is a non-lyophilized product and still a plasma-based product, you do have a broad protection against any type of transfusion-transmitted infection. And because you do maintain that, we're able to now take a product that was only 4 to 6 hours once thawed and extend that shelf life at room temperature up to 5 days, which is really, really massive for something like this. So what it allows us to do is it allows us to also take something that is not necessarily used, bring it back into the blood bank and reissue it either for another woman or for another patient in the hospital undergoing another procedure. And so the biggest thing that this has allowed us to do is to store our cryoprecipitate essentially on a wall at room temperature, ready to use, ready to pluck, so we can meet that urgent demand to provide early fibrinogen. These products come pre-pooled, which is also nice, and they come in multiple dosing options. The one that we currently use is this FC15, and so you'll see this here. And so 1 unit actually will equal about 1.5 vials of fibrinogen concentrate, and it's pooled from 4 different donors, and it's already pre-pooled and sorelin treated. And what's also nice is that you are providing that cryo product, so you are getting the other factors that are in there, like factor 13, so you're not just getting a purified fibrinogen. And despite all of the benefits, this actually comes at a lower acquisition cost than fibrinogen concentrates. So for us, we acquired this at about $700. So you're getting about $300 savings per unit compared to fibrinogen concentrate, and you're also getting about 50% more per unit. But then ultimately what it does provide is that it does provide an immediate availability. So we don't have to wait to thaw, and we don't have to, or our anesthesiologists don't have to do a painful reconstitution at bedside, which can risk kind of bubbles being formed, or just having somebody being taken away, having to manually stir essentially a vial while they could be doing other things. The biggest thing that this has allowed us to do is to shift our massive transfusion protocols. So with traditional cryo, because of that 30-minute wait time for thawing, we weren't able to meet demand for cryo in that first cooler, because this first cooler internally goes out within 10 minutes. So any cryo that was needed would have to go out in the second cooler at the earliest, and then subsequent even numbered coolers to again allow for that thaw time in between subsequent coolers. And so now essentially that this is ready to go off of the shelf cryo, we're able to now provide this in the first cycle of an MTP, and then we subsequently supply it in every odd cycle now. So these women are getting continued earlier exposures to fibrinogen. At any one time, we keep 2 of these pre-thawed on our walls. And then when one is used, our blood bank techs will essentially thaw the next one. And it does take about the same 20 to 30 minute thaw, but it's essentially a use one, thaw one cycle that we have. What this has also allowed us to do, and something that I think we're pretty excited about operationally to share, is this concept of a fast pack. And we've had this fast pack since 2023, and the fast pack typically for the rest of the hospital is 2 red cells and 2 plasmas. And this is essentially what we call like a mini MTP, or like an MTP cycle 0.5. It essentially allows anywhere in the hospital to have emergency access to trauma units 2 and 2 that may not have fridges nearby, like the ED has. And it allows them to essentially get that trauma blood without having to do the full-blown MTP. And so they can kind of kick the can down the road while still providing their patient an emergent source of red cells and plasma. And this has been great because also for the blood bank, every time we have an MTP activation, we are currently on a 4, 4, and 1, so 4 reds, 4 plasmas, and then 1 apheresis platelet. And so that's 9 cycles. And we always prepare the first 2 cycles upon activation. So every MTP activation gets 18 units of blood prepared and pulled off of the shelf and essentially unavailable for anybody else that needs an MTP. What this fast pack does is it essentially allows us to provide that blood without having to do the full activation. So it also saves our techs and it saves our blood supply. And we've seen that in that with all of these fast packs, we've only had 11 blood products wasted compared to 175 blood products that were wasted from MTPs over that same period. But now what's very exciting is that we've actually been able to make an OB dedicated fast pack. And so in addition to providing the 2 red cells and the 2 units of plasma, we're also able to provide this 1 unit of pathogen-reduced cryo. So this is a way for our obstetric anesthesiologists to essentially provide these women with an immediate course of emergent blood and emergent fibrinogen without necessarily having to go through that full MTP activation, to where they can kind of better assess what does the surgical field look like? What's the status of hemostasis? Do we really need to progress into a full-blown MTP? And it still allows them to do so. They're not prohibited just because they get the fast pack from going into an MTP. But it really buys them time while also treating this patient how they need to be treated. And so with this, we went live with this product on December 10th of 2024. So we just passed the 1 year mark, and the data I'm sharing pretty much looks at almost a year's worth of data. We had 41 either fast pack or MTP activations in the obstetric population over that time. And 34 of those 41, so 83% of those activations, transfused at least 1 unit of this pathogen-induced cryo. And what's important to note is that, when looking at a historical control, essentially of the same amount of traditional OB-MTP activations, where traditional cryo was given in that second cooler and not sooner, less than half of those received cryoprecipitate. So what that's essentially saying is that cryo was actually issued, cryo was thawed, but it was used in only, in less than half of those. So those 32 cases that were issued cryo, but didn't ultimately transfuse it, that's essentially 32 plus units of traditional cryo that was ultimately wasted. But what's even more important to note is that of the 34 activations that actually received pathogen-reduced cryo and transfused it, 83% of those started with that fast pack. So there was a really good uptake by our obstetric anesthesiologists to really first use that fast pack to be able to then kind of more mediate whether they need to actually go into a full-blown MTP. And even better, only 4 of those fast packs of the 28 actually progressed to MTP. So providing this pathogen-reduced cryo, providing this 2 and 2 early on, in addition to that cryo, actually staved off further activations. And ultimately what this means is that a whole bunch of blood products were able to stay on the shelf. So if you think about those 31 fast pack activations that would have been MTP prior to pathogen-reduced cryo, this essentially equates to almost 400 blood products that stay on the shelf. So that's a big benefit to our blood supply, the rest of the patients in the hospital, and also our blood bank staff to be able to better focus their own resources towards the rest of the patients. What was also important to note is that pathogen-reduced cryo, the first transfusion of that, was earlier than when traditional cryo would be first transfused in a case. So on average, the first transfusion of pathogen-reduced cryo was under 30 minutes compared to about 75 minutes for those receiving traditional cryo. And what that speaks to is essentially in the past, our clinicians having to bridge that time, that 75-minute gap, to use fibrinogen concentrate to essentially bridge that gap. And so because now we have pathogen-reduced cryo, we were able to get that cryo to them earlier, we saw fibrinogen concentrate use go down. So in all of the activations since pathogen-reduced cryo was available, only 20% of them had fibrinogen concentrate still be used, compared to about 60% of those activations when traditional cryo was only available. And then also the overall vial usage per case was also down when pathogen-reduced cryo was around. So about 1.5 vials were used per case traditionally, and then now we've dropped that by almost an entire vial, so almost $1,000 per case. And also important to note is that whether fibrinogen concentrate was used or pathogen-reduced cryo was used, there was no real significant difference in that time to first fibrinogen exposure. So essentially what this is showing is that pathogen-reduced cryo is superior to traditional cryo in our ability to get it to the bedside and also by what it provides, and it's non-inferior to fibrinogen concentrate for those same metrics, and it's at least cheaper. Looking at these cases, right at the level of significance. The estimated blood loss, or EBL, was lower in cases that were transfused with pathogen-reduced cryo than traditional cryo. And that probably is in part due to that earlier delivery of fibrinogen. And so blood loss was almost different by about 800 milliliters. And then overall blood component usage was lower, though not quite significant. And we saw about 2.5 units of blood being transfused less when pathogen-reduced cryo was on board compared to traditional cryo. And then similarly, there were no significant differences in hemostasis data, at least on our preliminary analysis, between both arms of this. And that, again, really speaks to kind of the non-inferiority of pathogen-reduced cryo compared to fibrinogen concentrate, which was used as that bridge when traditional cryo was on board. So ultimately, to conclude, we've onboarded quite successfully and operationalized this pathogen-reduced cryo for obstetric use at our large institution. But what it also allowed us to do is to create this obstetric fast pack that really enhanced early delivery of cryo with also similar suggestive effect as fibrinogen concentrate. And really, this reduced the need and the operational burden that obstetric MTPs really placed, especially on our blood bank staff and on our blood supply. And then even more so, it reduced reliance on that super expensive fibrinogen concentrate. And that's something that our institution is really trying to steward the usage of. And also, this has also provided some in-house proof of concept to be able to use pathogen-reduced cryo in other areas with high cryoprecipitate usage, particularly the transplant realms, which Vandy is definitely has a very high volume of here. So thank you all for letting me discuss this with you, and looking forward to any questions you have.
Thank you so much, John. Really appreciate that. I think we already have 2 questions in the chat. I'm sure more folks will join, but it looks like Dr. Maria Small has one in the chat about how, quote, hot or heat stability of fibrinogen concentrate, thinking about the warmer climates internationally.
Yeah, that's a very good question. I don't know the exact range offhand, but I do know it's pretty similar to anything that else you would see that is lyophilized, that you pull. It's the room temperature that they say, and obviously the ORs and the Pyxis units are pretty, well controlled. So I believe it's kind of that, 20 to 26, but I don't actually know offhand. But it is definitely a good point.
Thanks. And then Stephanie, you had a quick one. I think Vanderbilt hospitals, do they use EBL or QBL across the systems?
We use EBL here. Yep.
EBL, great. And then it looks like Elizabeth, you were first to raise your hand. Go for it.
Hi, Elizabeth Lang. I'm an OB anesthesiologist who has used fibrinogen concentrate and traditional cryo. One of the things I noticed is that in your MTPs, you weren't using the traditional cryo as frequently. Are they transfusing differently? There's no fixed ratio transfusion strategies for OB. And are we using lab directed to go ahead and give this new that you're using, or are they just almost using it in like a fixed ratio strategy?
Yeah, those are great questions. So it was originally operationalized when fibrinogen concentrate came out, that they would essentially, when they would reach a threshold of EBL and postpartum hemorrhage, that they would their order set would pull a fibrinogen concentrate. It was not lab directed resuscitation. As much as we would love to do that here, especially we have had historic issues with operationalizing TEG and things like that. And so even conventional coag testing takes a little bit of time. So our OB anesthesiologists and the obstetricians or surgical obstetricians that are there really just kind of use the gestalt and what they see in their surgical field to transfuse. In terms of balance, they do attempt a balance. And so they're pretty good about being able to transfuse a balance across it. And I'm sorry, remind me of that first part of your question.
I guess that was my question is, are we using it almost like a fixed ratio now? Because,
Yeah.
I mean, there is obviously a risk, although there are a lot less risks with the pathogen reduced cryo of giving blood products.
Yeah.
Uh,
Yep.
so, and when we look at like the OBS trials and such, we realize that most people don't become hypofibrinogenemic in an obstetric hemorrhage. So are we just I came from an institution, and my previous institution was very lab directed, but had this amazing quick turnaround on our lab. So it was
Yeah.
easy to do lab directed care for transfusion for obstetric hemorrhage. My current one does not. And as a
Yep.
result and lack of availability, actually they still use like one-to-one FFP to pack cells, which I think many people on this call would be like, that's silly. So are we kind of at Vanderbilt, are you using the pathogen reduced almost as like a fixed ratio instead of
Yep.
FF? Yes. Okay.
Yeah, we are, and I some of it does go to what does the level of hemorrhage look like, and you're absolutely right because even looking at the pre-fibrinogen or cryo or pre-concentrate fibrinogen level, and then the post. Some of these are, they'll go from 350 to 450 to 500. And that also, goes into kind of the question of, what is actually the level of hypofibrinogenemia in a pregnant patient? And is there levels of dysfibrinogenemia that exist, even though these levels are high, but they do really just kind of use it as a fix. We see this level of hemorrhage, and either we are going to give fibrinogen concentrate along with this amount of red cells and this amount of plasma, or now they're switching out the fibrinogen concentrate towards pathogen reduced cryo. And I think really the major change is we see that shift back towards cryo in at least a plasma-based product compared to the concentrate nowadays.
Thank you.
Yeah.
Yeah, thank you so much. Sorry, I had some technical issues. I'm going to blame it on the weather. It looks like Dr. Wong, you're next. And I know we're a little bit over. If folks have to leave, we completely understand. But I want to allow us to continue the dialogue if folks can stay on. Go ahead, Dr. Wong.
Thank you, Dr. Tucci. Great talk. I noticed that you got all the obstetric anesthesiologists on the call with questions. So I am also one of those. And my question is related to Dr. Lang's question, which is that I noticed that your OB fast pack still had FFP in it. So she's talking about giving cryo without lab directive. I'm going to ask you about giving FFP without lab directive, because I think we over-transfuse FFP in our obstetric population. The whole thing about the massive transfusion protocol was we wanted to mimic whole blood. And no one has shown in the obstetric population that mimicking whole blood during hemorrhage has a benefit versus just giving what you need, which is what Dr. Lang implied. But I would be interested in your thoughts about giving FFP as part of your initial resuscitation.
Yeah, you're absolutely right. And there's internal patient blood management discussions and revisions of guidelines, especially on the plasma side, that I think are trying to mirror that, and honestly, not just within the obstetric population, but other patient populations as well that we see in our hospital. And I think, to Dr. Lang's point too, as we are transitioning back to essentially more of a plasma-based product that has other things and has a larger volume than, fibrinogen concentrates. And that I do think that those are important things to consider of, maybe going back to this does allow you the ability to maybe strip away at least one unit of FFP for this, knowing that you are going to be giving the necessary things with a little bit larger volume, because you also don't want to necessarily, overload the patient as well. And so I do think that there's room there. It's not something that we've actively explored. And I think actually would probably be a very interesting next phase of this. And, right side by side with also kind of giving our lab-driven resuscitation, especially for these patients, to allow that to guide us as well. I think that's a fantastic point.
Yeah, thank you. And then Dr. Sarah Bell.
Hi, Jonathan. Thanks very much. Really interesting presentation. I haven't seen a product like that before. I'm based in the UK, in Wales, where we use a lot of Rotem and TEG to guide our treatments. And we now see obstetric coagulopathy as having maybe two phenotypes, either a dilution, which seems to be how your shock pack is playing out for these really big bleeds. And I saw in the data that the bleeds that you were describing were really large.
Yeah.
And you can imagine that there would, by the time the patients were being transfused, be a reasonable proportion of patients with hyperfibrinogenemia.
Yeah.
But how are you managing to identify and treat the patients who've got acute obstetric coagulopathy with this really early low fibrinogen early on in a bleed? And how are your shock packs addressing that low fibrinogen sufficiently?
Yeah, the identification is tough, to be honest. And I think honestly, in just knowing what our institution has been capable of and even seeing the data borne out in terms of when are we actually seeing the first TEG be ordered, and even more so, when are we seeing it being first resulted? It's actually quite problematic because, truly it's 90 minutes, 2 hours into the event, which is absolutely substandard, for being able to really identify the type of coagulopathy that's going on and how to actually address it. I'd say, for those that truly do, there's some still ability of conventional coag testing to have a little bit faster turnaround time. So you're able to at least get the raw fibrinogen number, as opposed to what TEG or Rotem offers. What the clinicians will do, and is what I kind of alluded to in the data, is that we still do see fibrinogen concentrate use in these cases. And so where there is a suspicion of more severe hypofibrinogenemia, we are able to provide that PR cryo, but then we still do see a bridge to fibrinogen concentrate and I think too, we see these more in the cases that progress onto the MTPs after the fast pack as well. And the advantage that we have too is that by having those two pre-thawed, we're actually able to also provide another PR cryo in that first cycle right after the fast pack. So they get 2 units of cryo earlier, and then we'll see a fibrinogen bridge to that third cycle. So if they really do feel like it, or if they are able to get an early lab, even if it is conventional, they will push more and more fibrinogen. But I still think, as kind of the trend is, it's very much a gestalt and just how they feel the surgical field looks. Is it kind of more oozy? Are there suspicions that that fibrinogen is going to be needed in addition to, just platelets or red cells?
Yeah, thank you for those responses and great questions. I would say, yes, echoing that, like if someone's going in, has an abruption, a chronic kind of abruption that becomes acute, you kind of probably have a baseline fibrinogen. So yes, those are the ones you probably would know. And I think it's nice to have as many options, frankly, to help manage these kind of patients, because some you don't know, some you do know, and it's very helpful to have all of them. So I want to say thank you again to both our presenters. And put a shout out plug for in 3 months in April, we'll have Dr. Emily Smith and Dr. Michelle Levin present. In the United Globe newsletter that's coming out in about a week or so. If you're not getting it, please feel free to email me or Sydney, and we can help you get on the listserv for that.